Welcome all. A few people are still sort of streaming in, so we will just wait a couple minutes until a couple more people can find their way here, navigating through the various links and sign-ins, etc. But yeah, I can just say a few words, I guess, about Open Digital Health in the meanwhile, while we're waiting. So this event is organized by Open Digital Health, which is not really an organization, but more of a collaborative that tries to look at ways in which digital health infrastructures can be made more open, more accessible, and eventually more effective for more people. And we have been attempting we have successfully built sort of a network of international people with an interest in open digital health tools, and are coming up with now some sort of a framework upon which we might be able to bring all of the available open digital health tools together and make them more readily available for use and dissemination. And as part of that building of the network, we organize events like this, where we have esteemed speakers with excellent experience in the area sharing their news and views on open digital health as a whole. And today we have also an excellent speaker here, Nanna Follman Hempler, who will talk to us in a little bit. And Nanna, I meant to also tell you regards from Robert Sanderman. He says hello, and he is unable to join today, but good to have you, he says. So Dr. Nanna Follman Hempler is a leader of a research group in health promotion research at the Steno Diabetes Center in Copenhagen, in Denmark, and is president of the Danish Society of Public Health. She has expertise in developing, testing, disseminating research-based interventions focused on sustainable care and health promotion with people among people with or at risk for type 2 diabetes. And her research focuses mainly on hard-to-reach populations, complex interventions, implementation research, digital public health tools, which I'm guessing we'll hear quite a lot about today, and design-based research, where solutions are developed and implemented in collaboration with end users and other stakeholders, including healthcare systems, patients, and members of the general public. So, President of the Danish Society of Public Health, Nanna Hempler, please go right ahead.
Thank you so much. And thank you so much for the invitation. I think I will just try and share my screen. Is it working?
Yes.
Mm-hmm. Yes, good. Yeah, perfect. So thank you very much for the introduction. My talk today will focus on how digital solutions can support navigation in chronic disease management, focusing on the pitfalls and how to overcome these, and it will be through a social equity lens. And as you also mentioned, I'm president of the Danish Society of Public Health, so I'm very occupied with how we develop interventions to not to widen the social equity gaps, but to reduce those gaps. And my research, primarily focuses on hardly reached groups, and I'm quite interested in how apps can support access and navigation in the healthcare system in general for these hardly reached population groups. See if I can. It seems it's a little bit stuck, so I cannot turn to the next slide. A bit strange. I think I will stop sharing and try again. Sorry for that. So let's try again. Now it works. So just some definitions in terms of the digital health. It's a very broad term, refers to technology, user experience, product, process, infrastructure of its own. And we know that the potentials are enormous. I know that probably all of you working in this field know that digital health tools can bring new approaches in disease management, more personalized care, high reach, and improve engagement with population with complex healthcare needs. I think we also need to take a little bit a look at the chronic care model. Maybe it's a little bit outdated. In Denmark, as well as in many other Western countries, we follow this American chronic care model. And we know that it improves health outcomes for people with chronic conditions by embracing longitudinal care and prevention across different sectors. We also know that there is a revised model, and this offers insights into the role of e-health tools in self-management support for people with chronic diseases. A lot of things has happened since the first chronic care model was developed. So we know that digital tools can support a productive patient-provider interaction as well, and it can also improve health outcomes. We also know that there is also a risk of these. We know that there are some inequities, and these existing inequities can be worsened. And in terms of differences in health literacy, the ability to pay for services, age, cultural attitudes, infrastructure around digital technology, and also in terms of a low socioeconomic status. And going into this part about the socioeconomic status, going into social inequities, which is my field, we know that these are systematic differences that exist between different socioeconomic groups, and these are socially produced and are considered to be unfair as well. And there is evidence that these social factors, and they include education, employment status, income level, they have a marked influence on how healthy a person is. And the lower the status, the higher risk of a poor health. And this brings me to the paradox of digital health, where you see an enormous potential in terms of reaching population groups. And we saw that in the COVID-19, I'll get back to that, but also having some underserved population groups that are likely to be excluded from these opportunities due to socio-demographic factors. Looking into Denmark, Denmark is really a digital front runner. We know it's the fourth most digital country in the world. Maybe it's actually higher now. This was a few years old. It's one of the most advanced countries in public health digitization. It has more internet users than any other EU country. And what is quite unique is that every Danish citizen has this secure digital key access platform where it actually goes across both the public and the private sector. So you can access all kinds of different apps integrated into the healthcare system, and also your bank and other fields. And these are some of the different examples of digital tools that can support self-management access for people, for Danish citizens. These are all funded by the Danish healthcare system and integrated into the Danish healthcare system. And I will come back to some of these apps that we have chosen to integrate into our intervention. This is just to give you an example of the My Health app, which was, we have some data before and after the COVID. The COVID has really pushed an enormous, it pushed the whole field in terms of digital health solutions. So we had 4 million unique visitors in December, and a year after, 8 million different visitors. And also you can see your test results. So we saw an enormous use of this app, both people using it and downloading it in a it's within only a year. So, but integration of these different apps is not always that easy. We know that there are many apps which makes it very difficult for people supposed to use these to navigate. Some of these are owned by the industry and are more profit orientated. There is really no real integration into the system. They exist, but they're not really, people are not being educated in using these different tools. And they're also very sector specific, so that for people with different chronic diseases receiving care in different sectors, it can actually be quite confusing to use all of these navigation apps for care coordination. This also brings me to digital participation, which we have been quite inspired by. Being focused on the digital health literacy, how can we improve that? This refers to the specific degrees of skills and abilities necessary to use digital health technology and services. And this will bring me to tell you more about the intervention that we have developed and are in the process of evaluating at the moment. We have just finished our data collection. So it's the intervention is on the island of Bornholm. It's a digitally supported health navigator intervention targeting people with multimorbidity. And just a few facts on Bornholm. This is Denmark. Denmark is a small country. This is compared to Ireland. You can see it's actually smaller. And you will see on the right there is Bornholm. So that Bornholm is an island that's actually quite far from Denmark. Only 40,000 citizens lives there. And there is a high prevalence of multimorbidity compared to the rest of the country. People are generally low educated, and there's a high prevalence of different risk factors such as smoking and obesity. So that's also why we chose this the setting, the Bornholm Island, to do our intervention. Because our overall aim is to increase access to healthcare services and health promotion activities for users with multimorbidity. We know that these people, they have there's a high demand on them in terms of coordinating their care, and they receive care in different sectors, and so it's extremely difficult. We also one of the criteria was that you have to have diabetes, type 2 diabetes, as part of your multimorbidity profile. We have been inspired by this systematic approach. They are inspired by the principles of equity relevant to digital, adapted from the Whitehead and the Dahlgren. So we looked into this. So what should we be aware of in terms of our own intervention? And we have particularly focused on 4 aspects of this systematic approach to equity assessment for digital health interventions. So improving status of those disadvantaged, strive towards provide primary health to all, should include the voice to the voiceless, and should facilitate equal access to services. And now to the different phases. We use the design-based research approach to involve participants. That participants are users, people. When I say users, I mean people with multimorbidity, local stakeholders, and healthcare professionals. And so they have been involved in all the different phases, including their perspectives, ideas, thoughts, and needs on solutions. And in the first phase, there is a needs assessment, which includes a mapping of access to healthcare and health promotion activities. We studied preferences and needs of people with multimorbidity and healthcare professionals, and we studied also readiness of the intervention. In phase number 2, we developed the intervention. We did look at all the different data and had a co-creation process with all the different stakeholders. We involved a user group consisting of 8 individuals with multimorbidity, and they varied in terms of gender, education, chronic diseases, and experiences. They've been following the project from both in phase 2 and 3, giving their opinion on this, on the development and the whole process in general. So now we are in phase number 3, which is the active implementation. We have just finished the data collection and now analyzing all the different data, both quantitative and qualitative data. But in general, we focus on the effective mechanisms in terms of what works for whom and how it works. So in terms of the needs assessment, this is just to outline, I'm not going to go through this, but just to outline all the different activities that we've had, interviews, workshops, user groups, and different meetings, also digital meetings due to the whole Corona situation a few years ago, and also user group meetings. And this is, I just wanted to show you this when I mentioned the mapping of the different healthcare activities. Here you will see both the different healthcare sectors, and you will see all the different things going on in the local community in the island of Bornholm, and how they're linked, sometimes linked to each other. And when we presented this to the users, the people with multimorbidity, they were quite surprised that there were so many different offers and things they could participate in and receive support and help. But they were also they said they didn't have this knowledge at all. They had not received this knowledge from their GP or other healthcare professionals. And even the healthcare professionals from the different sectors that we also involved in the process were surprised about the different activities in the other sectors that they did not know much about. So I guess it's quite difficult to navigate for people with multimorbidity, but it was actually also very difficult for the healthcare professionals to support them because they had difficulties in navigating themselves. So it was important for us to let the users' voices set the direction. And two very important findings, as you saw the map before, there were so many different services, but if you don't know if they exist, how can you actually use them? Digital solutions are very useful because a lot of these different activities are integrated into the different navigation tools, so you can actually find out what is available for you. But a lot of people they didn't know that these digital tools existed. They did not know how to use them. And they all meant you need someone to talk to, someone to also take you by the hand and help you and support you, both in terms of the digital navigation and also in terms of navigating in the healthcare system in general. But it was very obvious from this development phase that users, they want to get access to these digital healthcare tools. Some of them mentioned that they actually had downloaded it, but they had difficulties in using them. And they had not been able to receive support from healthcare professionals when asking. And some haven't even had the opportunity to know about these different solutions, and were actually a little bit surprised and asked us at the workshop, so why didn't anyone actually tell me that I could access the My Doctor app? So in terms of the development phase, we had a lot of different online workshops where we focused on the different data that we had. What should this intervention be focused around? What was important how to design it, and should it be focused in all the different sectors, and which healthcare professionals should be involved? Should it be group-based, individually based? How should these digital solutions be able to support the people involved, and so on and so on? So a lot of different methods in terms of being involved in this process. And we also use a lot of different consensus methods in terms of, we have a lot of steering committee, we have a project group, and really getting all people, the user group, getting everyone along and feel that everyone has a say in this, and being able to develop something that everyone could think is a good idea, and it could be, and is able to implement it in the island of Bornholm, which it makes sense in terms of people's skills and the organization and everything, their visions. So I will just briefly touch upon how the intervention is, the setup of the intervention. So the target group, these are also things that we discussed, by the way, in these groups. Who should be the target group? How should we recruit? Which digital tools, and so on. So the target group consists of people above the age of 25. They live in Bornholm, they have more than 2 chronic diseases, and they have complex healthcare needs. And we decided to focus this on a health navigator. We have employed 2 different navigators, and they were placed in the municipality or hired by the municipality, and their main task is support navigation for people with multimorbidity, and to strengthen their digital health literacy skills, and supporting communication with the healthcare system and also the civic society organizations. Then we have a multi-morbidity team with healthcare professionals from all the different sectors being able to support the health navigator and to be able to contribute with advice and guidance and actually go through the different citizens, going through their needs and helping the health navigators supporting people with multimorbidity. Recruitment was done through the healthcare professionals, especially people from the multimorbidity team, and also through health registries. We were able to locate those who fitted into the criteria of the target group who lived in Bornholm and contacted them directly, sending a letter. And then we also chose the different health navigation tools for the intervention. I will take you through these just in a little while. And also some people, they had preferences for accessing different websites that could also support their navigation. These were also part of the intervention. So just briefly in terms of how it actually works with the health navigator, people in the target group will receive an invitation to participate, and then they will be contacted by the health navigator to have a short conversation, also being asked a few questions in terms of being in line with the criteria for participation and so on. They will have a first meeting. It could be in the home. It's definitely the preference of the person with multimorbidity to talk about their needs, and which is supported by a tool. And they will find out whether digital health tools can support them and if they're already using those. And they will prepare and follow up and make a plan, and then also, of course, prepare and follow up on that plan. And you can have up to 10 visits or phone calls or what you prefer. So this is the need assessment tool that will be used at the first meeting. And I know this is in Danish. It says to the left, what is my biggest challenge? And then we have a lot of different themes in these to the right surrounding the person in the middle. And these are inspired by the needs assessment process. So you have you can have challenges meeting the healthcare system. You can have challenges with everyday life, diseases, finding your way, finding information, medication, not having enough support, or mental health issues. So a lot of different things that you could, so this is just for inspiration. You could also have other issues. So one of the apps that we decided should be involved in this is, so it's actually of course up to people to, if they want to know more about these different apps that support them. So this is the My Health app that I talked about previously, in terms of you can see your test results, but you can also see a list of healthcare providers in the municipality, eye doctor, GP, dermatologist, and so on. And there's also a list of all these health promotion activities in the local communities. It could be disease management programs, seeing a dietitian, and so on. Then there is the My SP, where you can see all your health information, test results, and notes from the hospital. And there's an overview of future hospital appointments as well. And there's also a possibility to contact the hospital. Then there is the My Doctor app, which includes easy access to booking consultations, vaccinations at the GP. There's also an online video function that some offer, not all. But there is a very comprehensive overview of treatment plans and your data. And then there is a medicine card, which is actually a cross-sectoral app where you can see all your current prescriptions. Yes, and you can also make a prescription renewal. And the e-box we found out is very important to include as well, because a lot of people cannot access this. You get all your invitations from healthcare services at the hospital in your e-box, so it's a very important app or web page to have access to, and to really know how to use and how it functions. So in phase number 3, yes, we focused on. We have a lot of. We have an interest in the whole process evaluation. So how is the study reached? How is the uptake? And how are the benefits for people with multimorbidity? And we're also studying the organizational barriers and facilitators. And we use different methods: questionnaire, observations, focus groups, workshops, and interviews with users. So these are just very preliminary results that I can present to you. We haven't finished the data collection completely. We are still having a lot of follow-up interviews and questionnaires to fill out. So we don't have a lot of end data yet, but I have some preliminary results that I just mentioned. These are from our baseline. We have included 64 people. These are Many of them have a short education, and they also have early retirement, although they are retired, although they are very young, but they're not capable of working. Almost half of them were recruited through the registries, and half of them through the healthcare professionals. And just to give you a brief example, this is the health literacy questionnaire, the e-health literacy questionnaire scale, and the ability to process information, ability to actively engage, motivated to engage with digital services. And this is quite low. I can just checked on some other studies as well, including ethnic minority groups and so. So this is actually very low in this group that we have recruited for this intervention. But we also see that there are some pronounced differences between those being recruited by the healthcare professionals and from the registries. Also some significant differences where those recruited from the healthcare professionals are have more resources. We can see that they are a little better educated. They score a little bit higher on the different scales, yeah. So we do see some differences in those two groups. These are examples of how we are analyzing the different data. We're doing this micro analysis from. We have a lot of information from all the different participants writing, because this is longitudinal. What are their needs? What are they being helped with? How does it in the follow-up? Do they actually feel that they are being supported, and does it work out for them, and so on? So we have a lot of data on each individual, being able to make these different analyses. So, and these are very preliminary findings, because we are interested in seeing what are really their needs and wishes, because it's a very broad, intervention focusing on the whole person, the wholeness. So what are actually their needs when we look into all these micro data? So people, they want to use digital health tools for self-management. That's definitely what we found out. And they want to get different devices also to support their disease management. They want to improve contact with the healthcare system, including also using digital tools. They also want to know more about possibility of getting financial support and more about their patient rights. They want to improve health behavior and receive more psychosocial support and get more network. And they want to access patient education and training in general. So just going back to how to overcome the different pitfalls, and just to mention also some of the lessons that we learned in this during this process. So in terms of data collection, because we could see that we had some pretty advanced scales, and these actually prohibited some of the healthcare professionals in recruiting the participants for the intervention. They thought it was too overwhelming for the participants to go through this data collection at baseline and also at follow-up. So that is definitely a barrier, and that is probably also why we see that those being recruited by the healthcare professionals have more resources compared to those from the registries. We did not see a difference in being able to answer the different questions, so it might be that the healthcare professionals are a little too overprotective of their patients, maybe. But as far as an intervention really wanting to recruit people who have really need this intervention, it's definitely a barrier that the healthcare professionals think it's too overwhelming for them to participate in this research process. And then also focusing on the readiness in the healthcare system, we did have a lot of issues getting the GPs to recruit. We have very few GPs recruiting the participants. They recruited a lot. It also tells us that there is definitely a need. But we also, although we had meetings and so on, it was so difficult to get the GPs to refer the patients to this intervention. So in terms of the first pitfall and just to give you some ideas about how did we actually work with improving the status of those disadvantages. Well, I think one of the things was we wanted to inspire everyone to use these digital navigation tools, but not all can use them or are not interested in using them. So it has to be an alternative for them and to be able to support it in other ways. And we focused on building these digital skills of the target group. And now we are be interesting to see, of course, when we get all the end results, if we have actually managed to increase the digital skills. And the health navigator should definitely also be involved with other capacities and being able to support people in the employment area, the social area. The health navigators were quite good at contacting different persons. That was also their role. And a lot of people had issues and problems that is not just concerning their health, but also it affects their health, but not being disease related. So also having really that broad scope on health. And then also building strong relationship with the civic society. That's definitely something that we need to, I think, could have focused even more on. That was a quite difficult part. The users mentioned that visits in the home was a very good idea. That's also why they were interested in participating, because it was so different compared to going to the GP, going out. It was much easier for them. It was easier for them to be in this, and they felt they were listened to and supported, and it was could be themselves when they were in their own home. And then follow-up was extremely important. Following up, could people actually access these different apps, but could they also, did they, after 2 weeks, 3 weeks, were they still able to access them? Did they have any issues? So not just saying, oh, now it works, but it really to have that. And as you could see, we did have those in the system, so the navigator could always go back and say, oh, you had this issue, you had this problem, I helped you with this, how is this going now? So really having this strong data-driven intervention. Number 2, in terms of primary healthcare, so the setting was quite important. That was also part of the design process, so including this in the primary healthcare sector, but also working together with the other sectors. And having a very broad focus on the mental, the physical, and the well-being of the person, and having, as I mentioned before, the whole person approach, and being more person-centered rather than disease-centered. And then providing voice to the voiceless. I think we really tried to do that by involving the users in the design and the implementation, and having this user group also following the project from at least phase number 2. We could have done it even earlier, and I think we would do that if we could do it all over again. And although the healthcare professionals often they say that they can represent the voiceless, it's really not our experience that this was the case. Often they had very different opinions on it, especially on the digital health tools, where the healthcare professionals said that people were not that interested in those tools. But I think to their surprise, they were quite interested. We saw that in workshops when we had users and the healthcare professionals also in joint workshops. So very important. And then the last bit, the human factor, to be a part of digitally supported intervention is extremely important. It could be, and also this is also being supported by the literature, a caregiver or a health navigator or coordinator, or someone, or peer support maybe, but you will need someone to support this when we want to reach the more hardly reached groups, and also the communication skills of those being involved as a health navigator or other roles, to have people can trust them, be empathic, have patient literacy, and having patience. That is some of the things that the users have emphasized is very important. Yes, a note to my key points. So access design and implementation should definitely be considered from the perspective of those being excluded, and involve the end users from the very beginning. I think we could have done even better in this. And remember the real integration of these digital solutions. It's quite striking that we have developed these and integrated these solutions into the Danish healthcare system, but they're not really being taken up by those who probably need them the most. And last, remember the human factor in digital health interventions to be able to reduce social health inequities. Yes, so that was my presentation. Yes.
Great, thank you.
Welcome. So maybe you have some questions or
yes, it
comments.
is customary to do the clapping in the online form there. Okay. Yeah, questions, comments. I'll just open the floor.
Thank you so much, Nana. As always, a fantastic presentation and great listening to the overview, how well this is structured in a Danish context. Every time I hear you speak, I'm truly impressed in how synchronized and how coordinated this is. My question would be about the cost and funding associated with the navigator intervention, because it seems like a really appropriate solution in terms of sending someone to a person's home, supporting them, guiding them through different tools, but providing up to 10 visits, to me, that sounds to be quite expensive. So I would love to just hear from you a little bit more in terms of who funds it, who supports it, and also what's the long-term plan for maintaining that sort of support. So if it's effective, would you be able to continuously fund that sort of service?
Well, that's definitely also something that we are concerned with. I think, so right now there is a funding, we have some funding that has made this possible. It's funding from the Steno, from a Steno project. What do you call this? So it's not really research funding, but it's funding for development projects in a sort of in a Steno setting. So hospitals working together with Steno, or healthcare system working together with Steno. So that has actually enabled this project. And we are interested in how can we, in terms of the sustainability and also the cost, and that will actually also be part of our evaluation. There's a lot of cost going to the research part, so we are of course focusing on how will this, if we're going to turn this into practice, how will this actually work? And I should also mention that not all people have 10 contacts. It's up to 10 contacts. We actually have a lot of users only having 2 or 3 contacts and having more or less just having some issues that will not take a lot of long time. Actually, often those being, they would like to get more support from these navigation tools. So they sort of get to know maybe my doctor, and then they will follow up on that. And then that's actually the intervention. So that's quite briefly. But of course, it's time consuming also to be in the home. But that's really something that I think is very important, because there are a lot of other offers in the healthcare system, but not really anyone making it possible to be in the home. And we had a lot of people that had very poor contact with the healthcare system, so they felt very safe in terms of being able to be in the home. What we would like to do, I think, in terms of also to say maybe some of these functions could be, that we saw from the health navigators, could be embedded into other functions at the municipality. And then we also considering, could we use the registries, because we really spent a lot of time on recruitment. That has really been a really issue here, also of course due to the COVID. But it's really difficult. So the registries have actually made it very easy. So could we somehow set up a project using these registries to recruit, and then embed the focus on digital tools and being able to go to people's home, into another, into some of we have preventive home visits, for example, in the municipalities. There are different health consultants. So could they take on some of these different tasks, and thereby being able to reach out to this population group that we are with multimorbidity as well. So that's what we are right now focusing on. I think that this that will be part of the evaluation, of course, to see how can we actually, what should we continue with, what works and what does not seem to work quite well. So so how could we do this? How could we optimize this going forward? Yeah.
And sorry, Nana, when you say registries, what do you mean?
Yeah.
Is it like a central system where you have lists of people who are accessing care?
We have a lot of different, we have a lot of health registries in Denmark, and also a lot of demographic registries. So we have information about everyone in terms of chronic diseases, in terms of contacts to the healthcare system, background data, your parents, your education, all of these things can be linked. Access to, so we do a lot of studies in that field, but you can also use it for recruitment for interventions, and we've done that several times. But it did seem as if it was a better method compared to having healthcare professionals referring patients to the intervention.
Mm-hmm. Again, I'm really inspired and impressed how integrated the system is, because I'm just comparing with, relatively fragmented Australian system, really fragmented system in the US. It seems like Denmark really has fantastic setup there to, coordinate and really find those people who need care the most, which is really
I think we do, but we're not taking advantage of those possibilities that we have. I think that's the issue right now in Denmark. Yeah. So we have the setup and we have all the possibilities, but we're not really using them. Yeah.
And there's so many ways in which so of course the data is there, but the data isn't always being processed, and the data isn't always linked to rules to indicate to a healthcare professional that, okay, you need to take this action now, or they would qualify for this program now.
Exactly.
So those sort of rules are really lacking a lot. Same is true here in Finland in both private and public sectors. And I'm guessing in many places the same issue is faced, that maybe the data is there, but data is only part of the story. You have to do something with it.
Yeah. So, but I think in the near future, and they're also working on this digital solution. As I also mentioned, there's so many different solutions which can also make it difficult for people to navigate. But right now they're working on something called a joint look into your health data. So it goes across the different healthcare sectors, and you can see your appointments, and you can see your disease, different targets for diseases, and so on. So you'll be able to access that, both person with chronic conditions and also the healthcare professionals from the different sectors. So that has also been part of our new health reform to push that development. So I hopefully in a few years we will have that solution.
Yeah. Great.
Yeah.
Alessio.
Thank you for the very nice presentation. I just have a couple of quick questions. And the first one is whether when developing the intervention, you had people with diabetes, but then any other chronic conditions, whether you noticed that, for example, people with certain combination of chronic conditions, such as diabetes and depression, had different needs and preferences as compared to people with, for example, diabetes and heart diseases, if that's the case.
We haven't really looked into that yet, but I think we will be able to do that. From the registries, we knew that people, we'd asked them to include a certain amount of chronic conditions, but we do not know which chronic conditions they had, only that they had type 2 diabetes as one of them. But we also asked them when we during with the questionnaire. But we haven't really looked into that. We could see, we did try to include people with different chronic diseases in the development phase, and we could definitely see that people, especially people who also had mental diseases, of course, they had different needs compared to those with only physical diseases. And they had, I think it was more difficult for them to navigate in the system and to be understood, especially when they access the healthcare professionals concerning their physical illness. I think that was definitely, it's a huge challenge for them to get some understanding, and because it's not integrated at all with the mental and physical health. So that's particularly difficult for them. Yeah.
Thanks. And the second one is about, I think you, if I'm not mistaken, you mentioned that the involvement of end users from the beginning is key. And if you had to do it again, you would probably do it better. So I was just curious to understand what would you do better? What recommendation would you give when involving end users?
I think I would have users involved from the very beginning, and not just from phase one, but actually involved in the designing the whole project from the very beginning. I've done that in other projects, and it really makes sense to involve people. We had a really good user group. They sort of been the most loyal people when you compare to all the different stakeholders in the project. They've been with us for 2 years, but they were only from phase number 2. I think they should have been there. They should have been there from phase number 1, and I think we should have included people while writing the protocol. Yeah.
Yeah. Thanks a lot. And congratulations.
Thank you. I will see when we look at all the different results. I think there are some really good learnings from this project, and we have not succeeded in all, but I think we have learned a lot about these kind of projects and how to that makes us even better for the next one. Yeah.
Absolutely, definitely. Now, on a slightly different topic, I would like to ask you about issues related to open science. So within open digital health, we're very keen to promote sharing of different digital health tools. We're very keen to encourage researchers and scientists to openly share their data. My question is about what's yours or what's your team take on open science? Are any of those digital health solutions open for other researchers to, or for other countries to maybe take yours as an example and replicate or attempt to replicate in their context? Are you able to share any of your data for other scientists who may be able to learn from the breadth of knowledge and breadth of information that you've gathered? If you could comment a little bit more on that, I would be very interested to hear.
Yeah, it's interesting because we haven't talked about that. I guess there are some regulations that could prohibit at least some of the data could not be open because we have these strong GDPR rules, the EU regulations. So I guess that could, but being able to anonymize some of these data could, I guess you could do that somehow. So we really haven't discussed it. I think actually, because I was asked this previously in another project as well, I think we need to have some discussions about this at Steno, how we deal with this, and because I think it's a really good idea in general to do it and to be able to share these data. But I'm not really. I need to be more. I need to know a little bit more about regulations and so how we can do this in the best way possible. Yeah.
Mm-hmm.
So,
I also think in terms of apps and solutions, it seems to me that so many other countries can learn from Denmark in terms of how well everything is integrated, how well everything is synchronized, which I think is very unique. And it seems like Denmark is at the forefront of having it really well thought through, really well set up. So again, if there was some openness to sharing those learnings with people in other countries, I think that could benefit public health and digital health internationally.
Definitely. And I think there's a language issue, a lot of things being written up in Danish. I've just participated in a survey because they were interested in the My Health app to make it more, they found out from those being responsible for the app that people with ethnic minority background are not using it very much. So what could actually be done in terms of that? So I participated in a large survey, and they will launch a report, I think, within the next few weeks. So that's definitely a step, and maybe but it's in Danish, I think so. But it could be interesting to have some of these different things being, because there are, of course, some things written down about these apps in Danish. I think most of it could be have it translated and then make it accessible on web pages and so on. That could be really interesting. Yeah, definitely. And then you should move to Denmark. Then you have access to all these apps.
That sounds great. Very
keen.
Get
your social security number, and and you can access. Yeah. So when you come to Denmark in August, Dominic, then you have to look into these apps. I can show you.
I would love to see them. Because we have not as well organized, but we also have it's called My Patient portal in Poland. And with recent situation in Ukraine, it's been translated to Ukrainian. So now it functions the portal is set in Polish and Ukrainian as well because of the need. And again, it could be set up in many other languages, but for some reasons, we kind of not yet changing it. So
yeah, I know also some of the IT people that have developed some of the solutions, some of the apps that I mentioned. They will also be at the conference, and I know that they are also active in the UK and other European countries, and being very interested in different kind of collaborations. And we have also been writing some applications with them. So they have all the technical insights, and so I think there's a lot of things that you could collaborate with each other on across countries for these, and use the Danish experiences with these health apps being integrated into the system. But of course, you need some funding you need awareness and interest from the authorities, from the public area, to be able to invest in this. Yeah.
Agree. Hopefully some EU funding.
Maybe some EU funding. Yeah, that could be great.
I have a question about the health navigators. What was their usual background?
Yeah, they actually, we were not. We had a job proposal, and it could be a nurse or a physiotherapist. We were quite open, but it ended up being 2 physiotherapists who got the job. It's very difficult to recruit nurses in Denmark right now, so I think also we need to focus on other occupational areas. So I think a lot of countries have issues with the recruiting nurses at the moment. Yeah, so we were quite open, but it has really worked quite well with the physiotherapist having a very knowing about rehabilitation, knowing about disease programs, being able to work together with the rest of the sectors and other healthcare professionals. So I think it worked quite well.
Okay, yeah, it's quite interesting. I think that type of role, like I know from my experiences in working in different universities, there's always the first person you always need to make acquaintance with is like the one secretary who knows who does what everywhere. And I think that these health navigators have a very similar sort of role to play across the health system, because as you had come out of your interviews there, that this is really nice, but nobody knows about this. If people knew about this, then it would be good. And that's a big challenge. So you showed all these different apps, but they're separate. They're integrated to the doctor system, so the doctor can sort of pass information to each of them, but they're all like separate clients that would run on a phone or so for the patient, right?
Yeah.
Okay. So in the interactions between the health navigators and the patients, do you have any insights into what types of things were most commonly discussed, or like which apps they were most worried about, or which ones merited the most or needed the most navigating, let's say?
Yeah, I think the medication app and the My Doctor app, a lot of people wanted to able to download them, or maybe they had already downloaded them but not able to use them. I'm not so sure about the My Health app, but a lot of people I think maybe they had already downloaded it due to the COVID, because they had to see their test results. Yeah. And we had an enormous test set up in Denmark. I think we've tested the most people in the world for Corona. So you had to access you could also access the My Health through a website. I think a lot of people in this target group would use a website instead of the app. But and it makes no difference actually. But maybe so. But they probably have only used this function with the COVID, and not really. And they could actually also see all the different list of healthcare providers in the area and all the different offers in terms of health promotion activities and so on. So I'm not sure that they were supported with that, unless they mentioned this as a particular issue they had. They wanted to have access to these activities. So it's really, the issue is also people would, if you don't know that things exist, you will not ask for them. You will not search for them. I think that's really an issue, and it really takes you will have to have a very good health navigator to be able to to find out what are your needs and wishes to support you and lead you to the right activity person in the healthcare system and so on. It really takes a lot, and you have to have a very good overview as a healthcare professional. Yeah. So that was also part of that job too, because things also change all the time. During in the municipalities, they change their office, they change their courses all the time. So they also need to be updated on what's going on all the time. They need to be much better at everything than the rest of us, basically. So that was also part of their job to sort of be updated all the time. Yeah.
All right.
Yeah.
Any other questions, Alessio or Dominica? I have maybe one more. Maybe okay question. So when you did these online workshops, this sort of co-design, I saw you had some sort of screenshots there in the presentation. Which online collaboration tools did you find, or did you use, or did you find worked best?
We used Zoom as the platform, and then we used Miro, which is do you know that?
I've heard of it.
Yeah. So to have these online to use, write post-its and present. We had the slides in Miro, and we had, of course, we did smaller groups, putting people into smaller groups, coming back together in the big groups. I think it was really a big challenge for a lot of people, ourselves included, to have so many different people, and it really took a long time to arrange everything. You need to have someone who's just on the phone being able to help people get online if something goes wrong. And so we also had a company that we worked together with in terms of presenting and facilitating the workshops, because I think we got a lot of better. We're used to fast facilitating workshops, but it's quite different in online workshops. So it was nice to get some support in that. And but I think we really improved. I think we had 4 large workshops during the development. We had the first one physically, that was just before everything went wrong in terms of Corona. But then we had 4 large and a lot of different meetings, of course, also online meetings and so on. But then we also were able to involve some of the users. We had some of the persons from our users group involved who felt okay with being involved in a digital development process. But it worked quite well. I think everyone were actually surprised in how well it worked, because I think expectations were quite low for this. But as a lot of things, they worked quite well during Corona with the digital solutions. This also worked quite well, and I think we didn't need to travel a lot, and so also some other things that we could get people would feel so safe also being at home. The users were sitting in their own home. Maybe it was also nice for them to, and some of them joined up and sat together, 2 people in the same home, and so it was actually okay. I think it worked very nicely, but yes, we did get some support for it.
Okay, yeah, that's,
for me, it's incredible, Nana, that you managed to do a research project with people who are not that good with technology, and you get them to use the technology. Yeah.
Well, that's it was also the healthcare professionals. They were not used to using this technology. So, we did manage to do it. Yeah, and it got better during the process. Of course, the first time was a little difficult, and then it got a little easier and a little easier, and But it was also during the same time as people were also using digital solutions for meeting their patients and meeting their family, and so I guess everyone was. They had a very they were learning just not in general to use these different tools. So I think that was maybe also why it worked okay. Yeah.
Incredible.
Yeah, Dominica, you cut out there, but it was like exactly at a time when you would maybe normally have stopped your sentence. So Nana just continued answering the question.
Sorry.
No, it was perfect.
My internet is a bit unstable. Sorry about that.
Smooth transition. It has been A pleasure, Nana. I think we can come to the end of this meeting, and yeah, thank you very much again for the presentation. Excellent.
Thank you
And
for
good to
having me,
see.
and thank you for a nice discussion. Yeah.
Yeah. Thank you. Thanks all.
Thank you so much.
Bye bye.
Bye.
Nice day.